Students, we are now going to the rate and extent of distribution. Factors that affect drug absorption, example, ionization of the drug, lipophilicity of the drug, size of the drug, pH of the environment, etc. Also govern the rate and extent that a drug will distribute to various tissues in the body. Additional factors that may affect the rate and extent of distribution include non-specific binding to proteins. Smaller molecules diffuse more rapidly, while larger molecules less so. Lipid-soluble drugs tend to be more distributed more widely around the body than non-lipid soluble drugs. Drugs may bind to albumin that is found in plasma, and this binding forms a drug protein complex that becomes too large to diffuse across the tight spaces in our capillary membranes. As long as a drug is bound non-specifically to a protein, meaning that it is not a target site now, it cannot have any therapeutic action whatsoever. And also, it cannot be eliminated by metabolism or by the liver or excreted by the kidneys. It's just too large. The heart medication, for example, the digoxin, it binds non-specifically to the skeletal muscles, to the heart muscles, I'm sorry, which is the desired effect that you want. You want it to work there. But when drugs bind non-specifically to proteins, their movement is limited, and it is as if the drug is being stored within a reservoir. So until those proteins let go of that drug is of no use to the body. It is just swimming around with these proteins attached to it because it's just, the complex is just too big to traverse across membranes. As was said earlier, the drug will more quickly distribute to areas of high perfusion. Remember, the heart, the brain, the kidneys, than areas that receive little blood flow like your skin, adipose tissue, skeletal muscles. Cardiac output, that is the amount of blood that the heart is pumping out at a certain time, and the local blood flow of various organs greatly influence the initial distribution of drugs. Therefore, if you have a patient with a heart condition that is going to affect cardiac output, then you may result in accumulation of the drug due to the decrease in the elimination process. Can't distribute to go to the kidneys, can't distribute to go to the liver to be metabolized, so it's just swimming around in your body and it will cause toxic effect. So the person's pathophysiological state will also affect how drugs are distributed. The distribution of a drug across cell membrane is usually determined by its pKa and pH on both sides of the membrane. And the difference of pH across a membrane influences the total concentration of drug in either side, since it's moving by diffusion. And at equilibrium, the concentration of the non-ionized drug will be the same on either side. We all know that mucosal lining of the GIT is impermeable to ionized form of the drug. And the ionized form of the drug we speak of is either the weak acid or the weak base. Most of the drugs are available as weak acids or weak bases. So ionization of drug will not only influence the rate at which a drug permeates the membrane, but the distribution of drug at equilibrium between the body compartments, once there's a difference in pH present between them. So if there is going to be a difference between the compartments, you're going to have the drug either becoming ionized or becoming unionized. And if it is becoming unionized, then the chances of it permeating the membrane is greater than when it is ionized. So that also not only affects the rate, but also the extent of distribution of the drug. Movement of the drug across the capillary membrane is done by passive diffusion. And the drugs are distributed across the membrane governed by Fick's law. And we would have done Fick's law in theory, in pharmaceutics theory already. So we know about the parameters regarding Fick's law. And the drug is moving from area of high concentration to an area of low concentration, right? And that is how we get the drug diffusing across our membranes and moving to different tissue spaces and perfused to the different compartments of the body. As larger vessels branch into smaller ones, the blood pressure decreases and movement of the drug now becomes diffusion or concentration driven. This is facilitated by the large surface area of the capillary network, and the pressure is higher in the capillaries than the tissues, pushing the fluid from the capillaries into the tissue. And this is known as the hydrostatic or filtrate pressure. Once in the tissues, the pressure is highest than in the venous system, draining the fluid into the venous system. So you're moving from area of high pressure to area of low pressure each time. And that is what is going to push your drug from one area of the body to the next, from the capillaries to the venous system, from the venous system to the capillaries in the kidneys, and it just pushes it like that because of the change in the pressure from one area to the next. If diffusion is rapid across the membrane, such that the blood flow is the rate limiting step, then distribution is known as perfusion or flow limited, right? So if it is that I can't get a lot of blood out because there's something wrong with my heart, say I have congestive heart failure, it means that I'm going to have impaired blood flow, which will reduce the cardiac output and therefore affect renal clearance, right? So if it is that it is affected by, or it is the rate limiting step, the flow of blood due to the heart issue, then you're going to have, it's going to be perfusion or flow limited. If the diffusion of your drug is slow across membranes into tissues, it's no longer affected by blood flow. There's nothing wrong with the blood flow now, but it is just slow in getting across the tissues, from the membrane across into the tissues, then it is distribution. The distribution is diffusion or permeability limited, and this may be as a result of the physical chemical properties of the drug now. It's just going across very slowly, either one, because it's too big, two, it is not lipophilic enough. So the extent of diffusion of drug is determined by one, the lipid solubility of the drug, two, the pH or pKa of the drug, whether there is plasma protein binding, and if there is intracellular binding. The drug may remain largely within the vascular system, and some low molecular weight drug, there are 4 types of drug distribution patterns, and one of them is that the drug may remain largely within the vascular system. It's not going anywhere else but in the blood. It's staying in the blood, it's swimming in the blood. Another type of drug distribution pattern is that low molecular weight water-soluble compounds become uniformly distributed throughout the body water. So the areas that you consider to be body water, that's where it's going to be distributed into. The third pattern is that few drugs are concentrated specifically in one or more tissue that may or may not be the site of action. So the example we mentioned earlier was digoxin. It has a particular affinity for the muscles in the heart. And in this regard, it's going to give you, it would be the site of action. All right. And the fourth pattern of drug distribution would be that most drugs exhibit a non-uniform distribution with variations that are largely determined by the ability to pass through lipid membranes. So this is just governing most of the drugs. Their distribution is varied because it is dependent on whether or not can it pass through this biomembrane or not. Is it small enough to pass through or not? Is it lipid enough, or is it too ionized to pass through? So these are the 4 types of drug pattern, drug distribution patterns. So the drug the antimalarial drug chloroquine may be present in the liver at concentrations of 1,000 times those present in the plasma, right? So it tends to be in a particular area than in the plasma. So it's not going to follow pattern one at all. It's definitely going to be concentrated in a particular tissue or a particular organ, in this case, the liver. Tetracycline is almost irreversibly bound to bone and developing teeth. That's why we do not give tetracycline to children, because their teeth and bones are still developing. So we tend to reserve tetracycline unless it is absolutely necessary, right? Because it's going to cause discoloration and mottling of the development of their permanent teeth. So we do not distribute, or we do not dispense, tetracycline to young children who are still developing. Another type of specific concentration may occur with highly lipid soluble compounds, which distributes in fat tissue. Now, we have to recognize that if our drug is distributed in fat tissue, it means it's probably lipophilic in nature. And remember, we said that the adipose tissue is like a reservoir holding our lipid drugs, like the sodium thiopental. Now, it is said that if this person, say a fat person, an obese person, is being given a drug, the dose would have to be adjusted because of this very fact that the drug is going to distribute, especially if it is it's going into the highly perfused area and then redistributes into the adipose tissues. Then it means then that the drug's mechanism of action is going to be shortened. And it means that that person is going to need much more dose, a higher dose than, say, somebody who is an average weight of 70 kilograms, for example. And the reverse is true. If the person now loses weight, all of those fat stores are now going to be broken down, and the drug is going to be broken down with it and now becomes free. So these are some of the things we have to think about when we are thinking about redistribution of the drug and the nature of the drug and where it is going to be distributed and how we adjust the dosing. Okay, so we are going to break here, and then we are going to come back and discuss volume of distribution.